We were discussing about preterm labor and preterm birth. Now the patient is, we were discussing the patient is in preterm labor, what we are supposed to give her. Like we already given her, if the tocolysis is needed, then we will do tocolysis with nifedipine and then corticosteroid and magnesium sulfate. We will give to the patient, and then we will next. Magnesium sulfate we have given to the patient for neuroprotection for the baby. Yeah, we have discussed this. And now we will discuss about intrapartum antibiotics whenever patient is in preterm labor. So we will give the patient intrapartum antibiotics uh, to prevent for the prevention of GBS infection in the baby, to prevent the early neonatal sepsis for the baby, because GBS is the leading cause for this problem. And we in the GBS guideline, GBS prevention guideline, we have the criteria of the patients which are required to have interpartum antibiotics to prevent the GBS. So we have the patients like who has GBS positive in the pregnancy, or she is having previous baby affected with GBS, or the patient with having prolonged leaking more than 18 hours. But there's also another point very clearly that whenever patient is in preterm labor, no matter she has ruptured membrane or she is having history of GBS or she has previous GBS baby or not, preterm labor is a clear indication for intrapartum antibiotic prophylaxis. So if we give the benzyl is the best option for that, but if we need to rule out the allergy, if the patient does not have penicillin allergy, we will give benzyl. If penicillin allergy is there but not so severe, then use cephalosporin with caution. Then we will, if the severe penicillin allergy, then use vancomycin. We will ask, if the patient is giving history, we will ask the patient signs of severe penicillin allergy. So what are the signs of rare penicillin allergy that patient that are clearly likely to be allergic in nature, such as anaphylaxis, respiratory distress, angioedema, or urticaria? Intrapartum antibiotic is given to protect early onset neonatal infection. So fetal monitoring in the preterm labor, explain the different fetal monitoring option to the woman and her family members or carers as appropriate. Being aware that we will tell the patient there is limited evidence about the usefulness of specific features to suggest hypoxia or acidosis in preterm babies. If we do the CTG and CTG is normal, this shows the baby is fine. If the CTG is not normal, it does not really say that baby is having acidosis. So positive, normal CTG is reassuring, but if it's not as abnormal, does not necessarily indicate that fetal hypoxia or acidosis is present. Involve a senior obstetrician in discussion about whether and how to monitor fetal heart rate for women who are between 23 to 25 plus 6 weeks. In established preterm labor with no other risk factor, offer a choice of fetal heart rate monitoring using either CTG, cardiotocography using external ultrasound, or intermittent auscultation. Fetal scalp electrode can be used, but they should not be used if the patient is less than 34 weeks. So do not use fetal scalp electrodes for fetal heart rate monitoring if the woman is less than 34 weeks, unless all of the following apply. So all should be there. But all those points, we can use fetal electrode at less than 34 weeks. But if it is not possible to monitor the fetal heart rate using either external CTG or intermittent auscultation, it has been discussed with senior obstetrician. The benefits are likely to outweigh the potential risk. Alternative immediate birth, intermittent ultrasound, and no monitoring have been discussed with the woman are unacceptable to her. So in the part 3 exam, there's a question of in the labor ward, there was a patient who is having there was a twin pregnancy at 27 plus 6 weeks, and the examiner asked that we are unable to find fetal heart rate on CTG. or we are unable to do the intermittent auscultation because we are unable to find the fetal heart rate. So one baby's heart rate we can locate and other is not possible. So but we have checked on ultrasound that both babies are alive. So what will we do? So this is the answer of that question, that if we will tell the patient that it's not possible, and we will involve our consultant and we will discuss the patient about the potential benefits and risks, and we will offer the patient whether we can do immediate birth or do cesarean section, or if she is not in advanced labor, or we can give the option of intermittent ultrasound or no monitoring. If patient does not accept all of that, then we will apply the fetal scalpel electrodes. But this can be done only for one, for the twin. It can be done for the one, not for the both. The fetal scalp electrode, discuss with the woman and her family members or carers as appropriate the possible use of fetal scalp electrode between 34 and 36 plus 6 weeks of pregnancy if it is not possible to monitor the fetal heart rate using either external CTG or intermittent auscultation. So if we need to sample the fetal blood, do not carry out fetal blood sampling if the woman is less than 34 weeks pregnant. Discuss with women the possible use of fetal blood sampling between 34 and 36 plus 6 week of pregnancy if the benefits are likely to outweigh the potential risk. When offering fetal blood sampling, advise the woman that if a blood sample cannot be obtained, a cesarean section is likely. And mode of birth, explain to women in suspected, diagnosed, and established preterm labor and women with PPROM about the benefits and risks of cesarean birth that are specific to gestational age. In particular, highlight the difficulties associated with performing a cesarean birth for a preterm birth, especially the increased likelihood of vertical uterine classical incision and the implication of this for future pregnancies. Consider cesarean birth for women presenting in suspected, diagnosed, or established preterm labor between 26 to 36 weeks of pregnancy with breech presentation. Timing of cord clamping for preterm babies. This is wait for at least 60 seconds before clamping and the cord of preterm babies, unless there are specific maternal or fetal conditions that need earlier clamping, like baby is needed to resuscitate. Position the baby at or below the level of placenta before the clamping. So this is all about the preterm labor. So if there's any question, then you can ask in the comments. Thank you so much.